teaching session. I'm glad to see a few names I know. So obviously, face-to-face would have been better interaction, but you have the message button there. If I ask a question, then you can write the answer there. Otherwise, there will be no interaction at all, which would be silly. This is, guys, how we look when we are in pediatrics and then they call us for an emergency. Obviously, this phase doesn't give confidence at all, right? And the way we remove this look and put a brave face, if we remember that in any emergencies, the guidelines are the same, and we have to follow them by the book. And if we do this, nothing will go wrong. And this is like what we have to think about when they call us for an emergency, the ABC. If you carry these few alphabets with you on your way to the emergency department, then nothing will go wrong. We'll go through a few scenarios to on each alphabet, and then we'll find out how we deal with these scenarios together. Yeah. This is a 4-year-old girl. Yeah. She was brought to the accident emergency with vomiting and persistent cough. This happened suddenly while she was playing. Yeah. And she has sore throat, and her voice has changed. Yeah, she's having spasm of coughing followed by retching. She doesn't seem to be getting better, otherwise well. And when you look at her or examine her, nothing but tender throat. Any thoughts, guys, quickly from the audience? You can talk or you can write something.
So I guess there's the common non super worrying things, like is it like a viral throat infection, a viral tonsillitis, something like that. Just with the spasms of coughing, very unlikely given the vaccinated population. But yeah. I make sure there's a whooping cough, something like that.
Yeah, so all the thoughts of come to your mind, but if you look at the ABC sequence here, right? If you look at the scenario again, something happens suddenly, right? It's a sudden onset. Yeah. Usually the virus infection, all of the stuff come after a few days of a fever, being unwell, but sudden onset. This should bring your mind whether there is any foreign body. Yeah. The sudden onset one is foreign body or anaphylaxis, right? We'll talk about this. Any causes for airway obstruction apart from the couple of causes I have said? Okay, well, obviously you said Hassan talked about infection, yeah? And I talked about foreign body, and then I said anaphylaxis as well. Obviously, this boy doesn't look like anaphylaxis at all. He's very good, isn't he? But he would be poorly if there was anaphylaxis there. We'll talk about this later. And then coma, obviously, because the coma, you can't control your airway, so it will be obstructed. And the edema obviously, because of inhalation of smokes when there is a fire, yeah? So the airway is the first thing you have to think of whenever you go to see a pediatric emergency, because this is the one thing you need to sort out, because this is what kills the children if you don't treat it, yeah? They always say treat first what kills first, yeah? So what kills a child from first is hypoxia, no oxygen, no suffocation, anything which stops the air going into the lungs will kill the child. So if you are treating the heart or the kidneys or anything, the child will die. You have to open airway and keep it clear all the time. So A first, yeah? So airway obstruction, one of the common presentations in pediatrics. These are the different reasons. And then the assessment, when you look at a child, you don't have to jump on the child and examine him. Use your eyes and ears and your all senses to, you'll find loads of signs and you treat loads of things before even you take your stethoscope and start examining the chest and other stuff. So when you look and you see, are they conscious, are unconscious, distressed, or comfortable breathing, or not breathing, or a secretion, all these, they don't need any examination, just look. Are they working very hard for breathing? Are they producing funny noises like stridor, which in our scenario will be upper airway obstruction, yeah? And then you can feel like the air would just coming nearer to the child and see the air coming in and out. So if there is an upper airway obstruction, you can diagnose it without examination. But in the situations where the child is comatose, right, and you want to open the airway, there are different maneuvers you do. Like for example, in infants, because of the back of the head is big, when you put them like a neutral position, the airway will be opened. In older children, you have to tilt the head back a bit in a sniffing position to open their airway. And sometimes you see a foreign body, you can remove it if you see it, but don't remove anything blindly. And if you see loads of secretion, vomiting and stuff, you have to do the sections very, very gently, because once you stick the section down into their throat, vigorous stimulation, then you change the scenario from upper airway obstructions into bradycardia, which we'll talk about later on. So this is how you open the airway. These gadgets, guys, when do we use these gadgets, please? I need to hear from you. When do you need to use these gadgets? It's one word. Go on. Don't worry if you get it wrong, because we're here like to get it right now. So what is that situation when you need to use these gadgets? One word. No? Any wrong word, anything?
Obstruction?
Well, this is when this is upper airway gadgets to open the airway. Which condition do you use to open the airway? Which condition do you use this gadget, please? When a child is comatose, right? Is that right, guys? Because what happens is like sometimes the child is not comatose, and you put this airway, the child will start to cough or vomit, and you make things worse, right? So if the child is going for is comatose, or there is like going to general anesthesia, they put this airway adjunct to keep the airway opened. Yeah, when the children are lying on their back, or even adults, their tongue falls backward, right? And then this causes upper airway obstruction. Does this make sense, guys? Can you say no, yes or no, if it makes sense or not?
Yep.
Yeah, thank you very much. Okay, so don't use these upper airway gadgets in a child who is conscious, right? And once you open the airway, whether this is like using the maneuvers we talked about, or you put upper airway adjuncts, then you start to give them oxygen. Once the oxygen is going there, then you have sorted out the upper airway and the child is safe. Oxygen is going to the brain, to the heart, to all organs, so you can move on. But without doing this, you have to sort the upper airway, right? While you are doing this, in a children who come in trauma, you have to be mind with the C-spine protection, yeah? Because sometimes children come comatose after being involved in an accident. And if you open airway without paying attention to the C-spine, you will end up on a child who is like quadriplegia, basically. Yeah. So we have to support the neck until you are given the clear that there is no C-spine injuries. Yeah. Forget about something called collars. Now we use the manual inline stabilization, use vacuum blankets, use blocks and tapes, but this collars now is out of the window, because if you think about a child putting a collar around his neck and moving anywhere, it causes a lot of damage more than protection of the spine. Yeah? Okay. There are situations of upper airway obstruction when we come across foreign bodies, right? If you look at this chest X-ray, do we need this chest X-ray, right? Yes or no? Any answer will do, guys. If you say yes, I'll support you. If you say no, I'll support you, because there are situations when you need to do an X-ray, but there is a situation when there is a foreign body when you have to get it out, yeah, before even you send the child to the X-ray. But in a battery like this, when you X-ray and you find it, you have to call for help from the ANT or the gastro. ANT is higher up, or the gastro is lower down. Yeah, so they can get it out. But sometimes you come across a child who has foreign body, and you have to do something else. It will be like you have to manage this child before you talk anybody else. Obviously, you shout for help, but if the child is coughing continuously, for example, right, you try to get this foreign body out. Yeah. Foreign body out, this is like you use what you normally do if you are sitting next to your friends eating together, and then he or she starts to choke. What are you going to do? You just give them a slap on their back to like relieve this food stuck in their throat. Yeah. Obviously, they're like, are you all right? Are you all right? Bang, bang, bang. Yeah, thank you very much. Give me a glass of water. And this is what happened. I'm sure a lot of people went into this scenario. But when the children come and they are coughing, then you start by giving them 5 back blows. Where is my cursor? Yeah, five back blows, right? And if they don't get this foreign body out, you give them 5 chest thrusts. Yeah, and then you alternate between the two. The same thing for older children. Yeah, 5 back flows or 5 chest thrusts or abdominal thrust if they are older, and you alternate until they get the foreign body out. If they get the foreign body out after 1 blow, that's fine. 2 blows, 5. You carry on front and back, alternate until you get this foreign body out. You don't like see a child who's coughing and to do chest X-ray. Is that okay, guys? Yeah. So sometimes you do X-rays unnecessarily, and when we should have done the 5 back blows or 5 chest thrusts, and this would have sorted uh, uh, the child out. I remember an X-ray which was shown to us a few years ago, where we find the X-ray is of a nail in the throat of one of the children. This was seen by the nurse, and she said, "Ah, there is a nail there." But the doctor who came and saw the child, she couldn't see the nail, and then sent for an X-ray. The child did not like the X-ray, and the child coughed and coughed the nail. And then we found the X-ray in front of us. Obviously, what is that? And then when we were told the story, and we put our resuscitation hat on, And we thought, okay, why didn't we do the 5 back blows and the 5 chest thrusts? And this was a learning experience, yeah? So you don't rush all the children with foreign body to the x-rays, um, sort them out this way. All right. Any question, guys, about this? Okay, I can't see any question. But Mina, keep an eye on the questions because I'm on the screen. I don't see anything, names or hands or anything.
Will do.
Right.
I've got it on the screen.
Yeah, thank you. So this is the child who's coughing, but when the child is unconscious, what to do, guys? Any answer quickly?
So make sure at this point a pediatric cardiac arrest or pediatric emergency call has gone out because
Yeah,
about the GPS.
correct. Asking for help will be very reasonable thing to do at this stage, and then lie the child on his back and assess the airway again, look, listen, feel, and then you start the CPR. You give 5 breath and start the CPR. Yeah, and this is how you think about it logically. You assess the severity, effective cough, encourage to cough, ineffective cough, conscious, as we said, 5 back blows, 5 thrusts, and unconscious CPR. Is that okay, guys? Is that yes or no, Mina?
Everyone's quiet, so I presume it's a yes.
Yeah.
Yes.
Yeah. Sometimes when they are quiet, I feel that I have sent the message. Sometimes when they are quiet, I said, okay, are they bored or do you know what I've said? Yeah, a bit of interaction, guys. Hands, waving, anything. Yeah. Okay. Yeah, this is the blank slide where I say any question. No questions, I move on. So this is the upper airway obstruction with different causes, with what you have to do. Obviously, you go, the ABC says the A, you shout for help, and then you manage the situation. But this was a foreign body, and then we'll move on. The cake. Who doesn't love the cake? This girl loves the cake, and she was in a friend's house eating birthday party cake, and then she became unwell. Yeah, you see, unwell and noisy breathing and a rash. So she ate the cake, felt unwell, noisy breathing and rash. This is completely different from the scenario when all of a sudden she had the problem because of the foreign body. Yeah. Is it clear now, Ahsan? Yeah?
Yep.
Okay. Obviously, in a child like this has upper airway obstruction, very anxious, urticaria, swollen lip, abdominal pain, diarrhea. All these are fine because some children with this, well, this anaphylaxis. But the key issue here, what is the key word here, guys?
Bridle.
Yeah, the audible stridor. The audible stridor here tells you, yes, this is the upper way obstruction. Yeah, this is when I need to do something. Is that okay? Yeah?
Yep.
Okay. Now, um, you have managed anaphylaxis or read about anaphylaxis, but this is sorry about the noise, this is my chair, but this is a brand new sort of algorithm for managing anaphylaxis. Yeah. Previously, there was 2 medications in this algorithm, but now the only medicine you will see here is the adrenaline. So basically, anaphylaxis is adrenaline, 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 and then if the child does not respond, adrenaline. Yeah. Obviously, you can see that they are describing very well the airway, breathing, circulation, disability, exposure, and the look, listen, feel, and then when you see the child should be flat or sitting like but not standing. And then you give intramuscular adrenaline, yeah, in the thigh. And then if the oxygen, establish the airway, flow oxygen, and the monitor. If they don't respond, give another adrenaline after 5 minutes and the IV bolus. And if they don't improve after this, then you move to the refractory anaphylaxis. This is the new addition to this, because this protocol was not there for children before. Before there was like give cortisone, there isn't any cortisone here nowadays. Yeah, it's adrenaline, adrenaline, adrenaline. And in this situation, as you can see, the ABC on the right hand side, but on the left, if you don't respond to the 2 doses, then you have to give start adrenaline infusion. What I'm supposed to do, the adrenaline infusion will not be ready in a minute, right? While you're waiting for the adrenaline infusion, then you give another dose of adrenaline every 5 minutes, yeah? Until things are ready. And obviously, in a situation like this, as Ihsan is saying, then an anesthetist, consultant pediatrician, all the people need to be on board to help you sorting out this. Yeah?
Yep.
Okay. Any question, guys, about this scenario? Okay, so this is another cause of the upper airway obstruction. We talked about foreign body, we talked about anaphylaxis, and then we will go to B now, the breathing. And with the breathing, I've chosen asthma because this is one of the difficult conditions we treat when they come, whether the children are non-asthmatic or they have asthma for the first time. It's always scary and heartbreaking to see a child struggling for breath, right? This child, 7 years old, it happens that he's non-asthmatic, so he is on the whole like cocktail of medications like salbutamol, inhaled steroid, long-acting suppositories. This, the more medicine they have, tells you that it's more difficult or complex or fragile asthma or brittle asthma, right? As we used to call them. Whenever he comes with the severe asthma, he responds to aminophylline IV or salbutamol, and he has a history of being admitted to PICU. Yeah, he came with difficult breathing at midnight. Obviously, when the junior doctors and the registrar are on call, but his breathing at that time was 32, heart rate was 150, saturation of 90. And decrease the air entry on both sides. Yeah, is this okay or good or bad or
Bad.
bad? It's just bad or very bad?
Very, very bad.
Very bad. Let us see whether it is bad or very bad. This is actually a readable, so I'll try to make it bigger. Oh no. Okay, the way I make it bigger, or I made it bigger before, is I hope this will work with you guys. I ended the show and then I did this. Do you see it now?
Yep.
Okay, so obviously the scenario did not tell us whether he was agitated or not, yeah? And it did not tell us completed sentence or not, yeah? And the scenario did not tell us moderate or marked accessory muscles, yeah? And the scenario did not tell us big expiratory flow, yeah? But the scenario tells us that saturation less than 92%, yeah? And the heart rate was higher than this, and the respiratory rate was higher than, so he is acute severe, but not yet life-threatening, yeah? In a situation like this, we need to treat him and at least give him to this side and not to go to this side, yeah? Let me see whether I still have my presentation. Yes, I do. And from the current slide. So this is the moderate, acute, severe, and severe. The management here, if you think about it, this asthma, this is a breathing problem, isn't it? Yeah. But still, you have to go to the airway because sometimes they have a virus and laryngotracheal bronchitis and the upper airway with the stridor included with the asthma. So you have to assess the airway and give the oxygen and then go down to the breathing where you give the nowadays frequent salbutamol and every 20 minutes and the added aprotropium. The addition, obviously oral prednisolone if they can take orally, but if not, you give IV hydrocortisone. The addition to the management of asthma is the IV magnesium, which in my view has changed the management of acute asthma like 100%, not 100%, like 90%, because most of the children who used to come to us and transferred, now with the magnesium, they can stay with us locally here, and we continue to manage them. It is a wonderful drug in my view, although some people are skeptical about it, but now it is in the British Thoracic Society guidelines of managing them, and I think they use it more in adults as well. Whether use IV isobutamol or aminophylline, the same, but when you use IV isobutamol, you have to pay attention to the lactate level, because if the lactate level is high, then you know that you are giving too much salbutamol, and you have to keep an eye on the potassium level as well, because the potassium level, the salbutamol decreases the potassium. Okay, so this is like the management of the asthma. While you are managing them, you have to keep an eye on like the signs which signs of like life-threatening sort of situation, yeah. And you'll be surprised to know that very, very experienced people can be standing next to the child, and the child falls asleep, and they say, the child now is comfortable because he is not making a lot of effort to breathe. And in fact, no, they are not comfortable, they are fatigued. They are unable to make that effort to breathe because they are about to go into cardiac arrest, for God's sake, yeah? So when you are managing a child with asthma, be vigilant. If you notice signs of fatigue, if they are unable to speak, if there is poor air entry, sometimes the wheezes you hear, it disappears, but this is not because you cured the wheezes, this is because the child does not take, doesn't have energy enough to breathe in and out. So absent air entry or poor air entry, absent wheeze, the saturation, the oxygen desaturation helps you. But if you decide to do a blood gas, yeah, you have to know what is normal for the PCO2 in an asthmatic child. In an asthmatic child, the PCO2 is low because they are puffing it away all through their asthma attack. When the PCO2 level is in the blood gas is normal, this is when you get worried. This is one sign of fatigue because they are retaining carbon dioxide. Because children with asthma have a prolonged expiratory phase and they get the PCO2 out. When they are tired, this accumulates. So it's a bad sign, yeah? My advice to you in a situation like this, and in any situations when you are managing your child, listen to the mother, right? When you see a child who is sleeping in the lap of his mother, you don't assume that this is sleeping Life is rosy. No, ask her, is he okay? Do you think he is responding to the treatment or he's tired? If she says he's tired, you need to escalate the situation to your consultant, your the anesthetist, yeah, because the mothers have something in them very strange. They pick up like signs earlier than anybody else. Yeah, is that okay, guys? I spent the like time on this slide because it was horrible to see one of the managing team insisting that the child is improving, and he did not listen. I had to escalate to his consultant and say, "Look, I'm not happy. Come." And when he came, the intubation. The child was on the verge of going to cardiac arrest. Yeah. Any question, guys?
Yep.
Okay. Let us move on to this child. Actually, he's 5 and collapsed at home. He was just playing, and all of a sudden, went down. Blue lighted, and they attempted obviously resuscitation. And when you went there, you found the sternotomy scar. Yeah, and the parents haven't arrived yet to tell you what the situation is, right? Any thoughts here quickly?
Congenital cardiac abnormality that will have surgery on it, and maybe now there's some level of syncope related to that.
Spot this, Hassan, this is spot on. Sternotomy scar means open heart surgery, means this child is more susceptible to cardiac arrhythmia than other children. The children usually get the arrhythmia because of hypoxia, hypoglycemia, dehydration, but we rarely see the arrhythmia. But when they have a cardiac sternotomy scar, you know that this is arrhythmia. In a situation like this, we have the algorithm of like managing them, and it's straightforward. Like obviously, when you see a scenario like this, you will obviously don't be distracted. First thing, just say, okay, airway, is the airway open? Give them oxygen, and then the breathing. He might have like pneumothorax, so you see how he's breathing, and you go to the circulation, and obviously on your way down the ABCD, you will feel you put obviously ECG monitors and feel the pulse, and then you decide, okay, should I go to the right and do the non-shockable one, and when they have a systole or no pulse at all, or it is like shockable, like VF without a pulse, and then you start to give the adrenaline if they are non-shockable, or give the shocks or they are shockable, and you repeat the cycles. And then while you're doing this, you think about the reversible causes of cardiac collapse, which like the hypoxia, hypovolemia, hypokalemia, hyperkalemia, or hypothermia, and the tension pneumothorax, toxins, cardiac tamponade, or thromboembolism, which is like rare in the children. What should they call them? The 4 H's and 4 T's, yeah? And you always go through the ABCD, otherwise things will go wrong. So you'll find this algorithm everywhere in the emergency department, and in a situation like this, you'll find a very good team to manage all this. But let us go through these ECGs, which will appear on the monitor when you go. The first one, guys, when you see it, obviously this is flat sort of line, and this means that the heart is not working at all. Yeah, and yeah, but Any caveats here when you see something like this?
Make sure the lead was attached.
Exactly. This is what we all need to do, because this could be machine failure, right? Check the leads are in good contact, check the pulse, and see that this is real. But if it is real, this assistly, this when you go, yeah, to the non-shockable rhythm, which is assistly or PEA, yeah. The second one, this is bradycardia, yeah. So what is the difference between the second one and third one then? On paper, there isn't much difference, yeah?
Presence of pulse on exam.
Exactly, the pulse. If the pulse is there, this is bradycardia. If the pulse is not there, this is the PEA, and the PEA again will go to the non-shockable rhythm, yeah? It's pulseless electrical activity. So this is the machine produces these activities, but the child is dead, yeah? So the flat line and the bradycardia you see without a pulse, the child is dead. Dead, you need to get them back to life by following the non-shockable rhythm is adrenaline every 3 to 5 minutes. Is that right, guys? Yeah?
Yep.
We said this, right? Hypoxia, ischemia, vagal stimulation, pre-arrest, right? You will again rarely come across primary rhythm disturbance. But if you come across an ECG where the PR is prolonged, yeah, that's fine. Yeah, the child is healthy. First degree heart block, what I'm supposed to do. Yeah? But when you see second degree heart block where the PR interval increase, and then missing one, then you need to talk to the cardiologist. The type 2 of the second EP block, normal PR, but they keep missing P wave. This is when we need to get an advice. Obviously, if it is complete heart block, again, cardiology input here would be valuable. Right. As we said, A, B, C, D, E, F, G, and D, F, G here I put because some hypoglycemia, guys, hypoglycemia, don't ever forget the glucose, yeah? Yeah, every child you come across in the emergency department, whatever the scenario is, what is the blood sugar, please? Yeah, you will find the people, obviously there are people who are looking after the airway and the breathing and stuff. So when you arrive, put something new, have you check the blood sugar. This might be the cure. You give them some sweetened fluids, and this will be, the child will be back to normal, right? Yeah. This was the brady side of it. The tachy side of it, like there are a few ECGs here. There is a difference between the first one and the second one. It's one word. What's the difference, guys?
SVT.
The P, huh? Somebody say?
Oh, absent P wave.
Yeah, the P wave is absent, and the P wave here, the first one, indicates that this is sinus tachycardia. You name it, fear and anxiety, fever, yeah, after exercise, during exercise. But when there is no P wave here, although you can see shy one here, but the rest of it, no. So this is supraventricular tachycardia, or SVT, which we'll talk about how to treat it. Obviously, this is ventricular rhythm, which if it happens, we have to do something along the line of the VF. Yeah. SVT, this is like you'll come across children who have SVT and sitting and talking, but their heart rate is sky high, more than 220, right? This is when you give them, put ice on their face, or unilateral, and I will say unilateral, don't do bilateral at all. It's unilateral carotid massage, or Valsalva's maneuver, like, and the easiest way is to give them a syringe, and from the narrow end, you tell them, can you get the plunge out of the other end, and or they give them a straw and play bubbles. So all these can get the pulse down, right? This is while the other team preparing the adenosine, which should be given rapidly in a vein nearer to the heart. But if there is no one nearer to the heart, you just give it and flush it with saline. Yeah. But you will come across SVT when they are unstable, and this is the situation when you give them cardioversion, and obviously cardioversion is when they are anesthetized, yeah, and it's 1 joule per kg is different from the VF when you give 4 joules, yeah, and yeah, the VT. Bizarre sort of complex, but wide complex, yeah? So these were the narrow complex, the SVT and sinus tachycardia. Now then the wide one, wide, bizarre, and this is when you need to do something, otherwise the child will die. Again, although you can see it in front of you that this is like VT, but you have to open the airway, give oxygen, take care of the breathing and the circulation. Again, they will come across this rhythm when the children are sitting and with the pulse and stable. And then you give them magnesium sulfate, the amiodarone, and delays with the cardiology. When they are unstable with pulse, you will give them cardioversion. This is synchronized one, like the SVT, 1 joule and then 2 joules. And the amiodarone and communicate with the cardiology. If it is pulseless VT, then you'll go through the pulseless VT, which shows here, yeah. Just get, yeah, this is the one on the left hand side, right? So this is a quick review of the different rhythms you will come across, whether it is narrow complexes or wide complex. Any question, guys, about this?
Would you use magnesium in all stable conscious VTs, or only if it's to solve the point?
This is one of the medications they use if they have the VT. So the answer would be yes.
Thank you.
Obviously, the second line, if this doesn't work, then you go for the amiodarone and lignocaine. But all of us, when we hear that there is some sort of VT, the first thing, like, help from the cardiologist, and start preparing the magnesium sulfate. Yeah. Right. This one is like trauma. Cool. When the child was ran out of the playground and then hit by a car, and then brought by the ambulance with the cerebral immobilization. This child like has oozing blood from his right ear, and the right lower leg deformed and discolored, and noisy breathing. Is noisy breathing here good? He's breathing but noisy. Is it good sign or bad sign?
Bad sign.
Why is that?
Because his GCS is 8, and that means his airway's dangerous, and here we can see his airway's probably closing up, and you've got evidence of a brain injury, so it's
Yes. Any noisy breathing, guys, means upper airway obstruction. Yeah. Obviously, heart rate is like high, respiratory rate is on the high side, capillary fill time 3 seconds. Okay. Blood pressure on the verge of going like lower, and he needs some sort of support because of the F2, which is P means like 8 on the Glasgow scale, as you say, so needs ventilation. And the more serious than anything else, this right people, which is silly. Yeah. So, but the management will go through the same sort of sequence. The airway supports spine. You give the oxygen, but definitely this child needed intubation from the outset because of the P1, which like is 8 and less. And this is again situation when you need to avoid the nasal intubation. Yeah. The intracranial pressure here is like a possibility because of the right pupil is dilated. Yeah. So the medical way of reducing the intracranial pressure is to normalize everything. So you normalize the temperature, the blood pressure, the blood gas, the blood glucose, analgesia, anticonvulsives, any electrolyte disturbance, give the saline or mannitol, and if there is a mass, you evacuate it. But before you go into the mass and you evacuate it and drain it, this obviously needs some neurosurgeon, which is not available here. So what we have here is the normalization of everything we can do. What is this, guys? What do these scans show?
Subdural hemorrhage?
What's that? Can you speak up a bit?
Subdural hemorrhage?
Acute subdural hematoma with mass effect. Yeah, because whenever you look at this, you see whether there is mass effect or not. Because sometimes you see subdural hematoma without mass effect, which they will say, okay, yeah, observe, it will improve. But when there is mass effect, this is where things need to be sorted out. What about this? What is this, guys?
Minimal midline shift?
Yeah. This one you can see that there isn't like convex, but this one is concave, and this is like the extradural. Do you see the difference between the two? Not between these two pictures. These two pictures, like they have this concave sort of pushing the brain. If you notice the other one, yeah, can you see the difference between the subdural and the extradural? Yeah.
Yeah.
Okay. So all these are time critical. Yeah, you have to do something. And also this one, yeah, this is like hydrocephalus, so you have to do something very quickly, and there's something very quickly, as we said, A, B, C, D, and transfer it to the right people. This graph tells you how the increase the intracranial pressure increase exponentially with the slight increase in the volume, and the Glasgow coma scale like drops quickly from 15 to 12 in that increase in the volume, but then any increase on this, it drops to 3. So it's this is how we say time critical. While you are managing this child and normalizing everything, as we say, you have to bear in mind that things can continue to go wrong, and you have to keep an eye on all these uh, signs and symptoms in front of you. But the one which I want to talk about is fluctuation or deterioration of the state of consciousness, because you can go to the child and find the child is alert, looking at you. He might give you a smile, but previously and after you leave, he falls asleep easily without him. And this is deterioration of the state of consciousness, right? And this is very important. And this indicates that the child has a problem in the brain. So we have to, because the other signs, blood pressure could be normal, could be high, right? Heart rate could be normal, could be slow. Capillary fill time, okay, we'll give him a bolus, yeah? And equal dilated reacting pupils, he might be closing the eyes, you can't see it. Abnormal respiratory pattern, he might be because he was crying. Focal neurology, obviously, if you don't examine him, you miss this one. Abnormal posture. Abnormal posture, decorticate or decerebrate, both of them are bad. Yeah, so you don't have to think of like which one is worse. Both of them are bad. This like significant brain injury, decorticate, decerebrate. They are ominous signs. Obviously, seizures, it's bad, but please pay attention to the state of consciousness. If there is fluctuation, you take it seriously. We all like the Cushing's triad because of the name and the memorize them, decreased level of consciousness, hypertension, bradycardia. But actually, if we have left or come across a child who has Cushing's triad, this is too late. The brain is stuck now at the base of the skull, yeah? Any question, guys?
Nope.
Still silence, okay. I hope that this means that the scenario is clear and the management is clear. Because I'm just like talking all the time. Yeah. Okay. Let us talk about this scenario of this boy, 7. He is breathing faster than he should. This is what the mother is saying. And over the last 3 days, he was not well. And then he started to wet his bed. Any diagnosis which comes to mind? Okay, guys, the children, they are toilet trained when they are, some of them are 2, some of them when they are 3. But if you come across a child who is 7, he was dry before and wets himself, always think of diabetes. I'll come back to you, yeah, thank you. I always think of diabetes, yeah? Recently wetting himself, always think of diabetes. Obviously, anxiety, stress, pressure, and also, yeah, you hear all this stuff, right? And the conflict in the family, yeah, that's fine, yeah. Just rule out diabetes, yeah? Because this is secondary enuresis and you need to rule out diabetes. Okay, when you examine the temperature is normal, pulse a bit on the high side, respiration is like on the highish side, but deep, and this is very important because this is the sign that this child has acidosis. Yeah, saturation obviously 100%, capillary fill 3 to 4 seconds high, is dehydrated. The white cells, guys. Any comment on the white cells?
High.
They are high, yeah. Is this like because of infection or because of something else?
Isn't it common for an infection to push you into a DKA?
Yeah, it could be both. So we have to bear in mind that, yes, this could be an infection, but diabetic ketoacidosis can have high white cells without infection. CRP is 13, again, could be infection, could be the whatever metabolic problems going in his body is raising the CRP a bit. Sodium is low, which is serious, and the urea is high, which is dehydration. Bicarbonate is low, is acidosis. Blood sugar is high, and glucose in urine, ketones. So this is diabetic ketoacidosis. As Hassan says, this is the blood gas which you need to do, because nowadays we rely on the blood gases to say whether this mild, moderate, or severe. And the guidelines, the principles of managing diabetic acidosis is to manage the acidosis, to manage the bicarbonate, and to get rid of the ketones, because this is like how they define the diabetic acidosis. You'll find these three things there in addition, obviously, to high blood sugar. Okay, the severity, as I say, we link it now to the blood gas, and the blood gas, the guidelines of managing diabetic acidosis is ever changing. So mild, moderate, severe. This is like they used to say we need to say mild is 5% dehydration, moderate 7%, and then severe 10%. But assessing the dehydration is one of the very complex sort of problems that people are still debating it until now, and they haven't reached a consensus. But I can tell you the only objective measure to know whether the child is dehydrated or not, if you weigh the child and you know a previous weight, you will know that this child is dehydrated 5 or 10 or 2.5 or whatever, because this is the only thing which can tell you that this child is dehydrated. But anyway, the newest 2021 guidelines tells you that mild and moderate, i.e. the pH of 7.2 to 7.29 or carbonate less than 15, assume 5% hydration. The moderate, 7.1 to 7.19, bicarbonate less than 10, assume 5% hydration. Right? Previously, this was 7% hydration. This is in the 2020 guidelines. 2021, they consider like this 5% dehydration. The severe is 10% dehydration when it is less than 7.1. We use British Society Paediatric Endocrinology and the Diabetes Guidelines, but and this is like the 2021 guidelines I was talking about. But sometimes we use the STRS guidelines, which the difference between the two, that the BSPD, they are a bit liberal on the fluids. The STRS are still tight-fisted about, give very, very small amount of fluids. The principle, again, ABC, you treat the airway will be open, the breathing will be fast, can't do anything. So it is all circulation. You treat the shock, and you give, everything is slow. So when you come across a child with diabetic acidosis, don't panic, because it's like he will be managed over 48 hours. Just to put the fluids there, and then you can have a cup of coffee and come after an hour to assess and start the insulin. Yeah, because the insulin you don't start immediately, you start after 1 hour. Yeah, obviously loads of blood to assess the fluid intake, the electrolytes, and the blood sugar, and you adjust the insulin or the fluids accordingly. Yeah. The one thing here that everybody is keeping an eye on is the cerebral edema, right? This can happen at any time, but it's usually in the first 24 hours, right? And when it happens, once you get the first sign or the doubt that there is cerebral edema, you go ahead and give 3% saline, obviously after calling your consultant and all this stuff. Yeah, it will not hurt the child if you give him a bolus dose of 3% saline. We call it 3%, but it's actually in real life actually it's 2.7%. And if it was cerebral edema, you will see the effect of this bolus instantly. Yeah. Any question, guys? I'll be quick, Mina, on the last scenario, because I can't finish without saying that the seizures, because there are new guidelines for managing the seizure. 6-year-old girl, mentioned department, prolonged seizure. She's non-epileptic anyway, so it's likely that she either missed a dose or a couple of doses of the antiepileptics, or she has an infection, or she has something else. But and when she came, you you manage her according to this protocol. The reason I wanted you to oh no, not this one. Okay, I'll get it. The reason I want you to have a look at this, because they added levetiracetam to the guideline. No, we don't want this one. I'll be quick. Wait. Okay. Hopefully it will work like the other one. Yeah, that's really nice. Okay, can you see this, guys? Yeah, so basically it's the ABC, as we said before, right? You don't see a child that's feeding and then you panic and you want to stop the feed. Give oxygen, because if you don't give oxygen, he will die, even if you give him all the right antiepileptic. And the blood sugar, sometimes they feed because I said they miss a few doses of the antiepileptic, or they have an infection, but they may have hypoglycemia, which a shot of blood of sugar will sort them out. And then you start the midazolam or lorazepam, and if they don't respond, another lorazepam, and then this is the new one. Okay, in the old guidance, they say phenytoin or phenobarbital, but now they say levetiracetam or phenobarbital, and I think the people will be like excited about levetiracetam and they will start it, yeah. And then this is when you reach this stage of the second line, you call the anesthetist, and then the anesthetist will do this. But if the anesthetist is taking time to do this, you can give another dose. You can give if the preparation with intubation is not complete, then you can use this one until they do the other arrangement to do the rapid sequence induction of anesthesia use. Is that okay, guys? Yeah, I thought I would like bring this to the attention, because last time when I talked to the guys, I was asked the question whether do we use levetiracetam in children, and at that time it was in the air, but it wasn't written. But now it is recommended that we can use it. Yeah. Any question, guys? Let me go and see you now. Yeah. So these are a few sort of scenarios we come across in pediatrics. So we covered the airway, the breathing, the circulation, and the trauma, and the diabetes, which is metabolic, and the seizure, which is status epilepticus. No question again?
Nope.
Okay. Z, I'll tell your brother that you don't ask questions.
No, that's okay. It was very well explained, Dr. Mansi. Thank you.
That's very kind of you. Let me, Dr. Brown. What is your name, Dr. Brown? Dominic. Any questions, Dominic? No? Okay. I will leave you in peace then. Okay. Mina, is that okay? I finished the 10 minutes late. Sorry for the next speaker.
No, that's okay. Thank you very much, Dr. Mansi.
Thank you. Bye.
Yes, thank you very much. And thank you.
Are we staying in this call? We're switching to another one for Jody.
Can you please stay on this line? And Jolie will be joining you. I think Jolie is already online.
Can you hear me?
Jolie, can you pipe up a little bit?
Yeah. Can you hear me?
Okay. Yeah.
You can? Oh, that's good, because I've got a headset on. I'm not used to wearing headsets. So can you all hear me okay?
And I'll leave the session now
Yeah, no worries.
for my appointment. I'll just stop recording. Okay, and I'll leave you guys to Jolie's capable hands and Anita's, of course.